Aloha, everybody. Welcome to our session on telehealth, which is one of our Title V state performance measures to increase the use of telehealth to our Title V programs. Actually, we're a little more ambitious than that. We actually want to increase telehealth use to all our Department of Health. It is a priority of our director, and it is a priority of our governor. So we just are really smart that we picked it as a Title V measure. So we'll be going over the different areas that we had to touch on to actually make this initiative move forward. So of course we have workforce development, infrastructure development, implementation, and continuous evaluation. And I just realized I forgot to introduce myself. So I am Sylvia Mann, and I am actually the supervisor of the genomics section in the Hawaii Department of Health. Is it okay?
Yeah, it keeps blacking.
Oh, it keeps blacking out? Okay. So we have been using telehealth for our telegenetics sessions for 4 years now as part of our regional genetics network, the Western States Network, that's funded by HRSA. So guess how I became the lead for telehealth? Because I was the only one doing it in the department. So in our division, I was the only one doing it. So I am the lead for our telehealth initiative for Title V. I'm going to have Leela and Christina introduce themselves when they come up, because they'll do a better job than I will. So, as I said, our initial work with our telehealth began with our telegenetics, which is expanding. Our region for our regional genetics network is Alaska, Washington, Idaho, Oregon, California, Hawaii, and Guam. So if you can think about those states, you realize how important telehealth is to us, because we have massive expanses of geography in some of our states and very big rural areas. And like our state in Hawaii, we have the Pacific Ocean between parts of our states, and we have to fly. There are no boats that go between the islands, so you actually have to fly between the islands, and airfares keep getting higher and higher, so it's very expensive to provide services in person. So we used our experience from our telegenetics work, and also we had very good support from our policymakers. As I said, our Director of Health has it as one of her initiatives. We have our governor who supports us. We have our congressional legislators who support us, like Senator Schatz, who is very, very supportive of our efforts in telehealth. We also have legislators that happen to be in very powerful positions, like the chair of the Senate Health Committee, who has benefited from telehealth. She tells her story of how she benefited from telehealth, and so she has been very supportive. That's Senator Baker from Maui. She's actually from a neighbor island, so she knows how important it is to have her constituents be able to receive health care from a distance. So we were able to get, as one of our state performance measures, that by 2020, 100% of our Title V programs will be using telehealth to provide services, education for families and providers. We developed a work plan, of course, as all of you do for all your initiatives. We have workforce development, like I said, for training. We have services and education being delivered by telehealth. We have the telehealth network, because you're going to develop a network, of course, in order to do telehealth, is functional by 2020, and that we're going to get reimbursement and coverage and reimbursement for services that are eligible to our programs that can get reimbursement for services by 2020. So in partnership with the Pacific Basin Telehealth Resource Center, where Christina works, and she'll describe this to you later, how they've been helping us, Pacific Basin Telehealth Resource Center is one of the telehealth resource centers that is funded by HRSA too. HRSA funds many, many telehealth resource centers across the country, including one national one that deals with policy. That's out of California. It's called CTEL, and I'm sure Christina will tell you more about that. And one based in Alaska that reviews technology. So they do technology review. So Christina will give you more information about telehealth resource centers and contacting them and all that stuff, because that's her job. So we had a training course we developed for our telegenetics people, because one of the things that our genetics providers told us was, we were never trained to do telehealth in training. What do you do? So we were like, oh yeah, that's right. We were never trained to do this. So we need to develop some training to give them some background on telehealth and also to give them some hands-on experience on telehealth. And Leela will be describing the whole training for you that we converted from telegenetics to telehealth. So we also looked at infrastructure, which is very important. Of course, you can have all the people trained in the world and no infrastructure, you'd never have telehealth. So we worked with the Pacific Basin Telehealth Resource Center, first of all, to identify who has units, functional units. Now, it's not just units, because way back when there was funding from the federal government for states to buy equipment and to do telehealth. And a lot of hospitals and other state offices took advantage of this money. And then when the money dried up, they kind of shoved their machine into the corner of a closet. And so they weren't used anymore for telehealth, but they still were there. But that's not a functional unit for us because it's not working anymore. We also had identified facilities that wanted to use telehealth but didn't have the capability. They didn't have the equipment, or maybe they didn't have the broadband connection, or they didn't have the HIPAA compliant software. So we identified those units too. And then we identified definitely that our district health offices, in Hawaii we don't have counties health offices, we have district health offices that are on our neighbor islands. They said, well, we don't have anything at all. We need help. So through our Title V funding, we were able to purchase the video camera, the laptop that runs the video camera. We used the broadband connection already that was in the office, and we bought them a rolling cart because they wanted to be able to move it. And then we use Zoom as our HIPAA compliant software, so we gave them a Zoom license. It was all very cheap. The webcams that we buy, you can buy the Logitech ones. I think they're $30. They're high definition too. Those ones, if you have one or two people, are great. We bought them one where you could have actually a meeting of 6 to 10 people. So those ones have an integrated microphone. I think those ones cost us under $300 for the whole integrated microphone and camera and everything. And then we provided them a laptop that I think was $300 too. So it's not very expensive to set up. And if you already have a laptop somewhere or a desktop and you just have to buy them a webcam, it's $30. One thing that we find helpful if you're doing this is noise canceling headphone if you're using this for the provider, because it's really nice to not have breathing sounds and hissing and things like that when you're talking through your video conferencing. So noise canceling headphones or desktop noise canceling microphones are very good. Our Telehealth Resource Center consultant in Arizona tells us, get the microphones that glow red when they're off and green when they're on, so that you don't accidentally say things when the microphone's on that you don't want the other side to hear. And she goes, so make sure that they actually have the colors so that you know when they're on or off. So I think obviously they must have had some problem with that in the past at the University of Arizona. So okay. No, yeah. Not with the Surface. Okay. So the other thing we wanted to do was, even though places say they had broadband connections, we also tested them out to check to make sure that it was good enough to do telehealth, because one of the things is that the worst thing is to have a connection fail, especially if you're giving services to a family. It's difficult when the connection fails and then they can't talk to you anymore, or if you're doing a big meeting and the connection fails. So we want to test their broadband. We also looked at mobile devices for families because our Zoom application that's HIPAA compliant can run on smartphones, tablets, on Apple iPads, on basically any device that you have that can connect to the internet. They have an app for. Because it's HIPAA compliant, we don't have to worry that even if we use it for meetings, it's still HIPAA compliant. So it makes it really nice for us. It's not super expensive. Our business license, only the person initiating the meeting needs the license, not everybody on the call. So if you have 10 people on a video conference and you have one person organizing it, only the one person organizing it needs to have a license. I believe our negotiated state rate is like $15 a month for the Zoom license. So it's quite inexpensive for the license. Because we're looking at using mobile devices in families' homes, we need to also look at connectivity at homes. And so one of the questions that I always raise to Christina is, isn't there somewhere where I can type in someone's address and I can find out like if they have internet or if the cell phone works really well or whatever, so that I know which device to bring? And she's like, that's a good idea, but we don't have that. So I'm hoping that sometime in the future I'll be able to do something like that. The other thing we're looking at is kiosks. So we have one community in Ka'u, and you might be familiar with Ka'u because that's one of the places that grows coffee. And they Starbucks buys all their coffee from them. They have a Ka'u brand of coffee. And they had our health insurance provider, our largest health insurance provider, set up a kiosk for their community at their community center. So it's actually a kiosk to do telehealth. So with the kiosk, the advantage is you know that there's going to be a broadband connection because you wouldn't put a kiosk there if you didn't have a good broadband connection. And anybody can go to the kiosk to get telehealth services. So that's a really nice way of getting telehealth services. We also had to look at the whole consent form, paperwork, because you're so used to handing something to someone, but that person is not in front of you anymore. So you have to make sure that whoever you're working with on the other side, or if you're doing it to people's homes, the paperwork has to get there beforehand. You have to do consents beforehand. You have to get that back, or you move to electronic consents and electronic paperwork. We found that it's nice to have the actual paper of diagrams or pictures or whatever you're going to show the family at the family side so that they can go move along with the paperwork with you. The consents, we generally have the staff at the office help us get consent from the family so they can actually sign it, because we haven't moved to electronic consent forms yet, but several other organizations do use electronic consent forms. We had to revamp our scheduling. We have to develop training for the site facilitators where the family is. We have to look at billing and reimbursement because there's different codes that are used for telehealth. And then we also had to make sure that people understood what the policies were, because things like malpractice. Does your malpractice cover you doing telehealth? Because some people might have malpractice policies that only cover them if they see someone in person. So things like that, laws of the state, like in Hawaii, we have a law that got rid of restrictions for originating site, which means that it's not restrictive where the patient is, so the patient can be at home, actually can be in their car if they want to, at the beach, I suppose. So we're still working through that, though, with that just got taken off a couple of years ago. And then, of course, our implementing. So once we have everything, all the nuts and bolts figured out, it's the implementing of the services to the public. And we just revamped and implemented our new TELEGENETICS service last month for following up for newborn screening. We have the staff trained, so they're already using it for training, education, and meetings. So that's really nice, because now the staff actually demand to have Zoom meetings. They're like, well, I'd rather have a Zoom meeting than a conference call because I want to see people. And it's really nice because you can actually see people's facial expressions. Even if they look really bored on the call, you can at least tell that they're bored. My big thing is sometimes a lot of these are at lunch, and I don't like to eat lunch while people are watching me on my high-def video camera thing. And then, of course, continuous evaluation. So we have built in our telehealth initiative continuous evaluation. So we have evaluation immediately when we get someone into training, and then we evaluate every 6 months on how well they're doing, what challenges they have, what successes they've had, so that we can get feedback to see what we should be doing better or if we can improve what we're doing. So, and I uploaded to the handouts on the site our evaluation form. So how we came up with our evaluation for our Title V state performance measure is I went through, yes, this is crazy, I went through all of HRSA's maternal and child health Bureau's national and program-specific performance measures. You know those charts that you always have to grade yourself, 1, 2, 3, or whatever, and then you have to get a score. So I went through every performance measure and pulled out anything that might pertain to telehealth. And then I made our own charts, our own grading. So I gave samples of that in the handouts. And so we'll leave questions to the end, because now Leela is going to talk about the specific training that we're doing for telehealth for our workforce.
All right, so I'm Leela Iyer. I'm a genetic counselor with the genomics section of the Hawaii State Department of Health, and also with the Western States Regional Genetics Network. So as Sylvia mentioned, the Western States RGN is sort of where this telehealth training that we developed came from. So initially the work that we did was looking at one of our performance goals from HRSA as part of the RGNs is to increase the number of providers that are trained to use telehealth for genetics, the number of sites that are using telehealth for genetics, and the number of patients seen. So from that, what we decided to do for our region, how to really increase the amount of providers that are being trained is we partnered with the University of Hawaii Distance Course Design and Consulting Unit to develop a training course. And so what we did was we expanded on some existing telegenetics modules and training resources that existed out there from other universities and other programs, and from other telehealth resource centers as well. And we tried to really tailor things to be current and up to date and focus on telegenetics. And then I'll talk about how we, transition that to telehealth, but pretty similar. So the training course that we have developed is a 3-part training course, which included 10 online self-paced modules that, our users could go through at their own pace in advance of when we were doing the in-person training. The modules included learning assessments that we developed as well to make sure those key concepts were really being communicated and understood. Webinars with expert presenters as well. So for telegenetics, what we were doing is one that was looking at real-life telehealth experiences. So, talking to people who have different clinic models and what their successes and challenges have been. And then also a webinar on business models, so how people can ensure their revenue streams are going well, or their contracts, or, different ways to make sure that this is something that you can convince your organization is not a loss of revenue to use. And then finally, the last part of the training is a one-day in-person training. So for our telegenetics training, we partnered with the Southwest Telehealth Resource Center, as well as the Pacific Basin. And then so really the idea of the in-person training portion is so that people can have hands-on practice with actual equipment, have a chance to play around and, get comfortable with using telehealth, have a discussion about, the latest of what's going on in policy in your region. What are the best practices to use when you're doing telehealth and seeing patients through that? And then also to discuss how do you evaluate your programs when you're setting up a program. We're in the process of getting that training course accredited as well for telegenetics. And when we wanted to transition the course to telehealth, really just, it was a matter of adapting the focus on telegenetics to broader use by a number of healthcare providers, public health workers, people outside of genetic counselors and geneticists, and focusing on examples of, the other Title V programs and how you could use telehealth effectively for them. So our online modules, just to give you an example of what they look like. So created a course. It has 9 modules for telehealth rather than 10, since there was one that was focused just on genetics specifically. Project of, we had a start here video, we had, voiceovers recorded for all of this so people could go through and either listen to someone reading them through the modules or go through it at their own pace with reading the text on their own. So whatever, people's different learning styles worked for them, they were able to get something out of it. The modules, the topics that we wanted to make sure to cover is, for people that starting from having a basis in understanding how to use telehealth and telemedicine to people that really have never thought of it before and need a step-by-step. But it's meant to be, an introductory course to thinking of how to start a program and what are the important things that you have to have in place. We also wanted it to be a way that we could create a community of people within the state that can rely on each other for advice and to, talk about what their successes they've had and what challenges they've had, and so that everyone could really, find a community, since we're all going towards this initiative and measure together as a state. So the module lessons, we do an introduction to telehealth and telemedicine, talking about clinical applications, different examples of clinic types and patient types that you can see, the processes of case referrals, so thinking of, when you're going to see a family, who's getting what information, who's setting up the appointments, all of the logistics of that kind of thing, talking and thinking about the technology that you can use. So, as Sylvia was saying, what we've been doing and for all the programs is really just doing it based on simple technology that you can use with a laptop and webcam, but also thinking of if you have the funding to set up a fancy telehealth room that's many thousands of dollars, that's great too, and that can be used for many uses. So we like to think about the technology. Things like how best to design a facility, things you would think of where should you be standing, what should the background behind you be, what kind of room are you going to use, how are you going to get creative about where to actually set up this program in whatever facilities you have and space that you actually have available. Policy, our best practices, so also thinking of what is different when you're seeing a family in person versus seeing them via telehealth, and what's different in body language or clothing or how you should deliver information or how things should be set up. Policy and legal issues, like Sylvia was mentioning, importantly, thinking of what are the laws and what's the current things happening with reimbursement or malpractice insurance or various things like that. Business models, importantly, thinking of if this is something you need to be bringing in revenue for, what are ways that you can do this, whether it's by contracts or how does the billing work for things, or how do you make this and show your, your program that this is a good program to start and isn't going to lose you a lot of money. And then also project planning, so just figuring out truly how do you implement a project like this, and how do you find your champions of who's going to support this, and how do you get everyone on board and engaged in going forward with this. So those are kind of the main lessons that we broke the modules down into in our training. Like I mentioned, we also have knowledge checks throughout, so you can see we have all the lessons here, we have little sub-lessons, knowledge checks to make sure everyone is, understanding what's been presented in it. And then the other important thing is really providing everyone a lot of resources. So there's a lot of stuff that exists already about how to start up telehealth programs, and there's a lot of stuff that's out there. Christina will talk about the telehealth resource centers, which is definitely something you should avail yourself to if you're interested in this in your state. Is connecting with them to help you. So there's a lot of existing documents, existing ways to evaluate programs. So that's the other things that we like to provide as part of the training is some of these resources. The other, like I mentioned, what we wanted to do is create really a community for these resources and make it so we're not just, training all of these staff and people working in public health and just leaving them out there then to be on their own to figure it out afterwards, after the training is there. So the other thing that we've developed is there's this site, and there's many other sites like this, but this one called River, or River, I don't really know, where basically it's a community where you can post resources, everyone can have discussions with each other and be users. You can have questions. It's kind of like a forum where you can post things and you can make private groups of all of the trainees and have all the resources available. So that was a thing that was important for us, is to make sure that everyone can still consult with each other and come to each other for advice and talking about what's going on with their process. The webinars as well, so that's the other piece aside from the modules is, having these webinars. So we have conducted them live using Zoom, recording the webinar with the option for later viewing if the timing of the webinar doesn't work out well. So that's always another advantage of Zoom. And the main one for the telehealth training was, like I said, these business models in telehealth, and talking to someone who's, an expert in that and what her successes have been. Our in-person training that we held in October, the main things that we wanted to focus on that were a little bit different was, one, just going over the modules and making, seeing what questions people had and what their concerns were. The other thing was a technology review, so actually looking at what is the latest technology that exists, outside of the usual things like the webcam and headsets. Where is telehealth technology going in the future? And so we worked with someone from the Southwest Telehealth Resource Center who's a technology expert and goes to the telemedicine conferences and knows all the latest robots and cool things that are coming out. So that's always good to think outside of the box, and if you do have lots of funding, all the fun toys that you can get with that. Also, an in-person thing that we felt was very important is telepresenting, so really thinking about what's the best way to present yourself when you're doing telehealth and being on camera. And then kind of the most important part is really just having people have a chance to actually play with the technology and play with doing a mock telehealth session. Because I think that's where a lot of people are nervous or hesitant to start using it, or, not sure if it's something that will feel comfortable. So having a chance to actually practice. And so, we made up some mock ideas of patient scenarios that people would be seeing families for, and just had people act it out on both sides, being the patient and being the provider. And that was really helpful for people to kind of see, how does it feel to be the patient? Does it feel like there's any limitations or, things that you aren't being able to be communicated well, and then as a provider, how do you feel? And really, it's just a matter of practice and being comfortable and not being distracted by seeing yourself in the little box in the corner of the screen when you're doing telehealth. So that's really the main thing of the in-person session, is giving everyone a chance to play around with some of the technology, and then also discussing the policy issues in person and up to date. And then the last thing that we go through in the in-person session is, how do you make sure you're evaluating your activities right? How are you doing, surveys to make sure that everyone is accepting this as a good use, and that patients and families are getting the most out of it, that the providers and staff are also feeling comfortable with it, and using that to do continuous quality improvement as well. So that's our in-person session. So far we've done one round of staff through this whole training course. So we did one training session in October. We had 14 participants, and it was a range of people from social workers, public health nurses. We had a dietitian. We had an audiologist. So people working on all of the Title V priorities really to come through this program. We have 2 more sessions planned for spring and summer of this year for state staff. And yeah, just really importantly now, it's collaborating with with all the experts and Christina at the Pacific Basin Telehealth Resource Center for local resources and making sure that everyone is connected and up to date with what the latest is in the state, and just kind of supporting everyone as they implement these programs. So I'm going to pass it over to Christina now to talk a bit more about her side of things. So.
Good afternoon, everyone. I'm Christina Higa, and I'm the co-director of the Pacific Basin Telehealth Resource Center, or PBTRC. As Sylvia mentioned, we are a HRSA-funded program, and HRSA funds 12 regional resource centers. So if you don't know your resource center, you can go to this website if you're not already working with them. And as Sylvia mentioned, we also have 2 national resource centers, one that focuses on technology that's based in Alaska, and the other, the Center for Connected Health Policy, focuses on policy that's based in California. Today I'm going to talk about partnerships and our collaborative efforts in telehealth initiatives that was just presented, and looking kind of stepping back at the infrastructure in terms of policy, because if you're going to implement telehealth in your states, you really need to look at the enabling legislation and laws, but also technology, and then kind of coding back into the administrative policy, administrative issues in this project. And then I wanted to end with giving 2 examples. They're also Department of Health examples of how they're using this beautiful framework that they just described, and they're both in slightly different stages of implementation. So starting with policy, the states have varying telehealth policies, and so it's really important for you to understand what you can get reimbursed for in your state, or if you're going cross states, you know, how it may differ in another state. For example, for Medicaid reimbursement, most states will fund interactive video conferencing. That's very common. However, only 21 states will fund remote patient monitoring. So that's like sending biometrics from home for chronic disease or ICU. Only 15 states will fund store and forward. So that's like a dermatology image, sending it back and forth. So that's really important when you're planning, you know, the service delivery and you're depending on reimbursement for sustainability. Also, 32 states for Medicaid programs will fund what they call a transmission fee. So if you're presenting a patient to a provider remotely, you can charge a fee for the use of your facilities. It's normally a very nominal fee though, but still, that's another area of revenue. Overall, in the country, there are 30 states that require a telemedicine consent form where you must receive the patient's consent before you provide telehealth services, but not in all states. And 36 states have private payer laws. So not all states also have defined private payer laws. This is, excuse me. This is the website for our TRC that focus on policy. And every year they do a policy update that reviews all states' legislation and laws and summarizes them. So I think that's a really important resource. In the state of Hawaii, you would imagine as an island state separated by water, we would have a flourishing telehealth environment. But unfortunately, and also because our concentration of specialists are on one island of Oahu and in Honolulu. But last year, a University of Hawaii survey found that less than 15% of providers in Hawaii are utilizing telehealth. And that's actually an increase. It used to be less than 5%. So I wanted to talk about our approach in trying to figure out why, what's the barriers and challenges. And for, feels like decades, but many, many years, we kept talking, kind of talking in circles. Everyone would say, well, I'm not sure if I can get paid. I'm not sure how much I'll get paid. I'm not sure what kind of services I'll get paid for. And on top of all of that, I'm not sure if my malpractice insurance coverage will be in place. So in January 2016, we held a telehealth policy conference, and Sylvia and other stakeholders sat on the planning committee. And what we did is we brought a wide range of stakeholders from healthcare providers, academics, the telecom companies, and also policymakers to really talk about the specifics of our challenges. And the results of that is we came up with a white paper that talked about the issues, but also how we can overcome those issues. And as Sylvia mentioned, we had very keen policymakers listening carefully, specifically Senator Baker, who introduced the bill. And in that year, we had Act 22 adopted, which is our telehealth bill. And I want to say that in 2014, we did have a telehealth bill on the records, law on the records, and it did say that there was parity in telehealth payment, which means if you provide a service in person and you provide that service by telehealth, you get paid the same amount. So in 2014, we had parity. Why was everybody complaining? Legislators thought it was good, but from the telehealth workshop, we saw there were many other prohibiting factors. So our Act 226, that is now our telehealth law, removed a lot of those restrictions, which included, for one thing, malpractice must be covered, Medicaid must pay for telehealth. Also, geographic restrictions are lifted. So, for example, the genetics program, Sylvia's project, used the University of Hawaii conference room for their teleconsults. We had really good connectivity. But when she put those claims in for payment, the local insurance company kicked it back because the university is not a clinical place of service. So now that's restricted. And now you can get paid if your patient is at home, is at a school. If you look at what we include as services, it's very extensive. Virtual home visits, mobile health, store and forward, remote monitoring, and interactive. I almost wish it wasn't named out like that, because in a few years something else will pop up and we'll have to change the law again, but this is very comprehensive. Secondly, you do need to have a Hawaii medical license. So if you're anywhere in the state and you're providing telemedicine services to a citizen in the state of Hawaii, you need to have a medical license. As Sylvia mentioned, we're getting leadership support from the highest level. Our governor has named telehealth as a priority, and our director of health has really shown that it is a priority, named as one of the top 3 in the Department of Health. And of evidence of this, the Department of Health hired a state telehealth coordinator, and we worked together with the University of Hawaii, our program, and the Department of Health, and we had a follow-up telehealth summit in October, and that was the launch of the planning initiative, which the Department of Health has taken responsibility for in creating a state telehealth strategic plan. It's not a Department of Health plan, it's actually the whole state strategic plan. And they're also convening a Hawaii Telehealth Council to continue the direct support from leadership. And this would be across departments. So we're anticipating directors from the Department of Health, Department of Human Services, Director of the Department of Education, Department of Consumer Affairs, and others. I know this is a child and maternal health care conference. I won't speak long about Medicare. That's a federal program for the elderly. But the reason this is important is because Medicare telehealth policies are very prohibitive. They have lots of restrictions. And a lot of the states have modeled their laws and policies against Medicare policies. So we've been trying at a federal level to change this. As Sylvia mentioned, our Senator Schatz is a huge advocate and introduced many bills, but it's actually a bipartisan issue. So a lot of support from all sides. And the latest really exciting news is that last budget bill that President Trump signed that kind of reopened the government, right? There were 3 telehealth references. That's Medicare Advantage, Accountable Care Organization, and expanding telehealth for telestroke. I'm not sure yet the analysis of all of that, but it's quite promising at the federal level to help make some of these changes. So now I wanted to talk about the other big infrastructure piece, which is technology. You can think of technology in really 2 different aspects. One is the telecommunication connectivity. So, your internet, what's your broadband, what's your speeds. And there's another thing that's popping up, the variety of the modalities of how you deliver telehealth. store and forward, remote monitoring, mobile health. And as Sylvia mentioned, we're starting to have to look at still in the clinics. Do we have connectivity in the clinics? You still have a reason to convene in a conference room. You need a big conference room. But now we're talking about at home using mobile technologies. We're talking about kiosks. If you don't have the access to the home, we want people to have a place to go to access the technology. So we're seeing community health centers, rural health centers. We're seeing churches. We're seeing markets, pharmaceutical markets and things like that, of places where people can go to access services. And the other thing that I'm happy to hear is these kiosks are being discussed among many different agencies to potentially share it for telehealth. But the whole idea is to provide access to these rural areas. Equipment is the end user equipment. It's the video conferencing equipment, the speakers, cameras, but it's also the telehealth peripherals, so all of the scopes and different health equipment. Our Resource Center, this is the website. You might want to log that down. It's the National Telehealth Technology Assessment in Alaska, and their website has a list of consumer report type of reviews of various scopes. You can request for information and demos. Also, you can request for hands. They're in Alaska, but if you're having a conference, you might invite them, and they do a roadshow where they bring all different kinds of equipment. And we found that very useful because when you're able to, as Leela said, play with the equipment, it gives you a better feel for that and how you might be able to use it. The infrastructure here I'm talking about is at the project level. So the policies, what kind of policies do you need to change? What's your workflows and protocols and the forms? Forms for keeping track of your equipment, for billing purposes, for the consent forms, and there's a different way of doing things. So that all has to have the infrastructure for the administration of your project needs to be there. And here is a sample of a project I'm going to talk about next, the early intervention services. And this is a list of their table of content for their telehealth protocol. I just want to give you an idea of what people put in it. So it's an introduction to telehealth, but it's also the second one is, how do you discuss this with families? When do you bring it up? When do you explain this service option to them by telehealth? How do you formally put it into the individualized family support plan? What are the technical requirements and equipment? The Zoom platform, as Sylvia mentioned, how do you use that? What are the guidelines for the primary care provider, the coordinators? And then you want to go through your troubleshooting. Troubleshooting, things can happen at home, things can happen at the office where the consultant is. And finally, you need to talk about securing devices in the field regarding HIPAA. So finally, I wanted to mention the implementation piece. And this really great framework that Sylvia described is very useful. It's a process to go through when you're implementing your telehealth program. But I just wanted to take a time to acknowledge that, her group was able to come up with this framework, as she mentioned, because it was built on their success of their telegenetics program. And Sylvia is known as a leader in telehealth in our state and region. She was doing it and getting paid for it more than before a lot of people figured it out. So we consider her a subject matter expert, but she doesn't do telehealth as her full-time job. A lot of people in Hawaii think she does, but I really wanted to point out the fact that it was a solution to her. She had a mission, she has goals, she wanted to move her project forward, and using telehealth was the way to do that. And I think that when you're starting to implement your project and you're going to change the way people do things and their workflows, you're going to have resistance. But if you can keep everyone with that vision that this is actually helping us move to meet our goals, and it may not make their life easier, it may have less travel, but that's, I think, a really important part of your planning. So finally, I wanted to talk about two projects. The early intervention services, the way that they're currently providing their service is they have a Department of Health primary care provider travel to the home to give services to the family, and a specialist will fly, most likely from Honolulu, with them. And that's about a $200 round-trip plane ticket. So it's not only cost, but the time that's costly. And what they want to do now is still send the primary care provider, but equipped with a Surface Pro laptop, Zoom video conferencing, speakers and all of that to the home. And the specialist stays in Honolulu, and they connect up by Zoom from the family's home to the consultant. So how did they go about planning their initiative? They started to identify how they could use telehealth and improve access, maybe frequency of the consults. They attended the online training program as well as the pilot program that Lila just explained, the in-person. They also established a telehealth working group that was really expansive, including all the people who are going to be involved in this project, including the managers, the service providers, the specialists, the SMEs, but also the family advocate representatives. And that was really important because they were able to get feedback. And the feedback was the families were worried that the services might be diluted if they're getting it by video and not in person. So that's really important because within the whole structure of it, they had to get, good evaluation and feedback so they can monitor that and also maybe explain the change of direction of the program to the families. They develop protocols, then they're piloting it. They're going to pilot, evaluate, modify, and then hopefully be able to scale up to the rest of the state and in their service delivery and other service areas. Oh, by the way, this is the working group meeting, telehealth working group meeting that's held over Zoom. The last collaborative is between the Department of Health and the Department of Education and our federally qualified health centers. This is hopefully the start of a telehealth school-based network. And I know that some states have very evolved networks, namely Texas and Georgia, for example. But in the state of Hawaii, we don't have school-based clinics. Up until about 3 years ago, we have 3 now. And the nurse aides have a requirement of high school graduation, so they're not qualified to administer medication. So the Department of Health Chronic Conditions is kind of leading this initiative, starting really small with asthma. So the use case is, let's say the school just cut their grass, caused a child to have an asthma attack. She used her inhaler. Our state laws currently requires her to go to the nurse aide's office. Nurse aide calls the parent. Parent has to come, leave work, come and pick up the child and bring the child home because there's no one qualified to do an assessment. So what they want to do is have the child go to the nurse aide office, connect up by telehealth to one of the school-based projects, have the RN or provider there use a digital stethoscope and do a video interview and make an assessment and say the child is okay to stay in school or not. Okay to stay in school, goes back to class, still notify the parent, you get a phone call, but not to leave. The parent does not have to come back to the school and leave work. So you can see it's very feasible, and actually this can be expanded to many other applications. And I'm very excited because I think the potential for this is huge. So in looking at everything that we said today, I know we mentioned a lot of small details, but kind of at a higher level, I tried to pull out some of key things in your approach in implementing telemedicine projects. One is getting the buy-in at all levels. So that whole idea of the overarching vision and keeping everyone on board because it is going to modify and bring change to your workflow. It's very important to keep the vision there. Planning among a wide range of stakeholders, everybody involved, even your IT guy. Your IT guy needs to understand how this fits in the big picture, but he also needs to understand why the lighting is important, why you need a closed door, why the connections needs to be reliable and backed up. Training, like Lita said, leveraging and modifying existing frameworks, adapting it for relevant to your population, partnering within your departments and outside, piloting, with your infrastructure, administration infrastructure. Human behavior is really interesting. Sometimes we can take something that worked and put it somewhere else, totally rejected. But other times you can just find innovation. Like, I didn't even think people would use this technology that way, but human behavior is amazing. So piloting it, taking some of the things that you find and then repackaging it is really important. And what Sylvia mentioned, the metrics. So as they're planning their telehealth program, we're already saying, how are you going to measure this? What do you need to measure? How are you going to measure it? Modify it, you know? And then you have a model. And then if it works, you can scale up if necessary. Mahalo.
So, does anybody have any questions or comments or need a TRC to help you?
Oh, it's the microphone.
We have to run a microphone to you because they're recording the session, so they need the questions recorded.
So can we use your trainings? Are they available for us to use for ourselves and
So,
others?
as we said, we ran our first round of training in October. So we are tweaking our modules, and we are actually adding a registration portal to the front of it so that you can register your trainees. To the back end, we have automatic evaluations that will then take the back end database and send out the 6-month evaluation. So once we get everything all set up, our goal is to be able to just release that to all Title V programs across the country. So we want to make sure it doesn't break first because our big problem is that, you know, we can give it to you, and then if it breaks, then, you know, you have no support to fix it. Whereas if we keep kicking the tires and make sure it's okay, then we can give a better training to everybody. We also, I think you'll need some time planning on working with whoever your telehealth experts are in your state, because the in-person training part is really important to the online modules. If you just did the online modules, you'd have a good background on telehealth, but you would never know how to do it for your own part of what you do for work. So working with our TRC, we're lucky our Telehealth Resource Center actually is in Honolulu, and then we've worked with our Southwest Telehealth Resource Center. And some of you may wonder, why are the Hawaii people working with people in Arizona? Our closest Telehealth Resource Center was actually at UC Davis in California, and when we approached them to help us, they said they were too busy, so we just went to the next one that was closest. So we get that question all the time, like, did you like Arizona? Or, you know, something about the sun there or something. So that's the only reason that we didn't work with. And the Pacific Basin Telehealth Resource Center actually didn't exist when we first started doing this for telegenetics. So that's how come we went with Arizona, and they've been wonderful partners with us. So eventually, yes, this will be available to everybody as soon as we get everything all set.
How about your slides for today?
It's being recorded, so it's everything is recorded, slides and the talk and everything.
Hi, I'm Rachel Hudson from Colorado, and we do specialty care for pediatrics throughout the state and underserved communities. And we have been doing telehealth for several years, but have not converted to 100% telehealth. And so we are on that journey. And we have just experienced variation by specialty in terms of how they like to manage that first visit versus follow-up visits. And you may have said this and I missed it, but in particular, I'm curious about neurology and how you are managing neurology visits. Are you doing just right out the gate assessment and all follow-up visits can be telehealth? Or are you doing in-person visit for that first one and then follow-up by telehealth?
So neurology is not part of our services under Children with Special Health Needs. The kids actually do get the neurologists that go to the neighbor islands that do in person. So for our genetics visits, right now we're doing just follow-up for newborn screening with the telegenetics. In the past, and we'll start this again is we got new geneticists, so that's why we had to restart. We did the initial visit with our outreach clinics, and then we're doing follow-up with the telegenetics because the doctors still like to physically touch the kids, especially for genetics, because the evaluation is quite complex. In other instances, like our behavioral health in the department, some practitioners never have met the child in person. Some practitioners require that they see the child in person at least once a year. So they're pretty flexible in going with what the provider wants, because some providers, like when you're doing a counseling session, as a behavioral health specialist, do you really need to touch the child? But they just prefer it that way, and we're like, okay, that's fine. So we're still working through those kinks. As I said, that this is a new initiative for our department, so it's getting people's heads wrapped around the fact that they might not touch people. In our evaluations, the funniest thing for us is that parents and families love telehealth, telegenetics especially. When we also do surveys of the providers and the facilitators. Our geneticists rated it lower than the families rated it for satisfaction. And then finally I asked our geneticist, why is it that you don't rate it highly? And she goes, well, number one, I never rate anything a 10, ever. That's just my personality. And number two, I know I don't have to touch them, but I like to touch them. So I don't want to rate it a 10 because I really like touching them. And I'm like, stop touching them. Right? So, it's a balance. Families love it. Providers might not like it so much because they're so used to actual physical contact, especially in Hawaii because we're very huggy. They really like physical contact.
Virtual hugs.
All right, we have time for one more question.
Thanks, Paige. Ralph Schubert from Illinois. Do you have experience yet using this for newborn hearing screening?
So that is the next thing that we're implementing because we were ready to go with because we have very few audiologists that will do diagnostic testing on newborns on the neighbor islands. So unfortunately, then that means that the newborn isn't such a newborn by the time it gets to Honolulu, which means that their diagnostic testing means sedating the child, which we don't like to do. So we went and we actually hired a consultant who is an audiologist who works in this area. And he found out that at that point, that there were no published standards for diagnostic testing for teleaudiology for newborns. So I have been told that recently there are, so we will be revisiting that because that is a very important area for us because we want to stop having those kids need sedation to have their diagnostic testing.
Okay, yeah, sure. I just wanted to, I'll just do this one. With the geneticist piece, I mean, that's a very specialized field, and I was just curious, how did you start so far up in the type of practice? I would think like basic, medicine would have been easier to start with. Just curious.
Well,
We are genetic.
I run the genetics program in the health department, and I pay for the outreach clinics. And we can only have so many outreach clinics because it's a very long and full day for them. And we thought that to be more efficient, we could do some follow-up by telegenetics instead of wasting a spot when they have to fly over for the follow-up. Because a lot of the follow-up is, this is your test result, and remember we told you that if this came out, then this is what you have to do for treatment and management, and we'll see you in a year if you have questions, and we'll follow up with you. And then I happen to also run the newborn screening program too. So we have a lot of alpha thalassemia newborns. We have 35 positive carriers a month. And so we wanted to make sure that parents on the neighbor islands didn't have to spend a lot of time getting off work to fly to Honolulu just so we could explain what alpha thal carrier status meant. So that's why we really wanted to continue telegenetics because this is one of the things that where they could get the genetic counseling and the testing to do the DNA mutation analysis without having to fly to Honolulu to get it. So yeah, that's why it's a high level. Like, yeah, primary care would have been a lot easier. But there was no one else in the department that really wanted to do anything with telehealth. And like I said, it's a double-edged sword because we started it, so that means now I'm the expert in it, which I'm not. And Christina always makes me go on these like state committees and all this other stuff. And I'm like, okay. So we've learned a lot about telehealth. And then because of I'm also project director for our Western States Regional Genetics Network. And so telegenetics was one of the solutions in helping families get access to genetic services because most geneticists are in urban areas. And there's very few of them, getting fewer because they're retiring and no one's becoming geneticists. And genetic counselors, although more and more are graduating, more and more are going into industry rather than clinical care. So we had to find a solution, and telegenetics is one. So now I've become much more of a telehealth expert than I ever wanted to in my entire life. Would like to get out of this. I could. So that's how come. That's the only reason. Isn't that what it happens in all health departments? Like some area needs something, and they just go and do it? So. Okay, well, thank you, everybody. And if you need the slides, this is being recorded with our talk, so you can watch it over and over and over again.